Good morning. My name is Sheila Bolfa, and I am going to go over my Falls Initiative for my 405 clinical capstone. One of the biggest problems that we've seen this fiscal year in our hospital have been falls. Statistically, fall rates range from 2.6 to 7 falls per 100 patient days, and almost 23 to 42% of those falls contribute to at least one type of injury. With those injuries, hopefully you don't have an injury in a hospital, but one injury can lead to the hospital coming out of pocket a good $13,000. Obviously, that could be a whole lot more. So what are we going to do about our falls in our hospital? The data that we pulled for the med-surg unit was that in fiscal year 2019, the falls per 1,000 patient days were 2.27. That's actually a very good rate to have if you're going to have falls in your hospital. However, in fiscal year 2020, keep in mind this is whenever COVID happened, the falls increased to 4.25 falls per 1,000 patient days. Respectively, in 2020, we saw a total of 12 falls, 7 of which were during COVID. This is going to be important information whenever we get a little bit further down in the slides. So what we're tasked to do is come together and do a model for improvement. We did the PDSA. PDSA is to plan, do, study, act. So in this video, I'm going to go over what each step in that model means. The planning stage is whenever we get together and create an interprofessional and interdisciplinary team. This doesn't necessarily have to do, all nurses just because it's on a med-surg unit that the falls are occurring. You want to get multiple staff involved at different levels, leadership, staff level, and different departments. Ancillary departments are very important to figuring out where your opportunities are. Once we get our interdisciplinary team together, which normally starts out at the leader level of all ancillary departments, we sit down, we look at data, and we hypothesize what is the lead cause to the increased falls. This is called a root cause analysis. A root cause analysis can be a very lengthy process. In terms of our fall initiative, in the end of 2019, we had actually bought chair alarms, brand new beds with alarms. So we thought that, that was going to decrease our falls, and obviously it didn't. So we had to get together and say, okay, we thought, A and B was going to help with our falls. It obviously didn't. So what are we doing wrong? What more do we need to do? And then in the planning stage, we also have to set goals. You have to be very mindful that you don't want to create goals that are unattainable. You don't want to go from having 12 falls in a fiscal year and say, oh, I'm only going to have 1 or 2 falls in a fiscal year. A good way to do it would be with percentages. Each month my fall rate will decrease by 1%. That's an attainable goal. So underneath the plan, like I said before, we have the root cause analysis. So with our root cause analysis, we looked at alarm and call bell response times. Again, we're going to go back into COVID. Whenever our nurses are donning the PPE that is required to go into COVID rooms, it's a good 5-6 minute process. They are stuck in the rooms for a very lengthy piece of time, and they are not on the floor whatsoever. We've also had staffing issues. So little staff, more staff having to be in an area where they can't hear call bells going on because they're very critical patients that they're taking care of. It made us not have as many staff members actually at the nurses station able to hear phones or down the nurses station. If somebody was in a room, they're expecting that if they hear an alarm that someone's going to run to it, but that wasn't always possible. So we had to look at, the staffing issues and why these response times were not being handled in a more time appropriate manner. We also had to look at ancillary collaboration, because we know in our hospital that throughout the daytime especially, you have ancillary staff such as environmental services, dietary, you have leaders walking all around the hospital, you have x-ray, you have lab. We wanted to look and see, is there anything more that they can be doing to help to prevent these falls? And last but not least, something that we always need is education. Once we find what we believe our root causes are, we're going to, in this planning stage, put together some educational tools to implement. So we next go to the do stage. This is where we actually start implementing and doing all of the education. So we come together and we determine what we are going to try to do, what we believe our root causes are, and then we educate our staff on them. We give them guidance as they start implementing what we're asking them to implement, and we also make sure that we sign competencies. Competencies are very important in facilities because it allows you to hold accountability. When you have a signed competence and you see that someone is not doing what we are supposed to be implementing, and it could have potentially led to an injury or a fall of some sort, you're able to go back to that competency and coach these individuals and see, was there any further education, or were they just not doing what was asked of them? So when we get to the actual interventions, there are several interventions that we put in place. I'm only going to name a few of the big ones. One of them is the no pass zone. No pass zone was implemented at bigger campuses, and I actually did a literature review on them. And with the no pass zones, we saw a 35% reduction in falls. A no pass zone is teaching every single ancillary department that when you hear a call bell, teach them how to answer it. When you are walking down the hall and you hear a call bell, a chair alarm, a bed alarm, you go straight to the room. When you are walking by a door that is open, you peep in and you see if there's anything going on that would warrant your presence being in there. So one of the things with the no pass zone is that a lot of the staff may not have felt comfortable. Oh, well, what if they need to go to the bathroom? I'm not trained to bring someone to the bathroom. I just bring dietary trays. We don't expect our staff to do things like that, any type of intervention of toileting a patient, turning off an IV, dealing with an IV. What we are teaching them is at least we have the presence of a body inside the room to allot a little bit more safety and stay with the patient, call with the call bell until somebody can actually come in. Even if it's just hanging your head outside of the door and, yelling for someone to come, to do those things. Your nurses are stuck in rooms sometimes. They don't hear these call bells. They're not able to get to you. So if we have ancillary departments doing this, it should greatly reduce our falls, is what we are thinking. And this is for everyone. CEO of the hospital will also be required to do the no pass zone. The no pass zone education has gone out. Each leader is respectively going to be teaching, and we're going to have audit tools and things of such to do a private surveillance to see how well it's going. This extends even to our CEO. If he is walking down the hall, he is expected to abide by the no pass zone. Another thing that we initiated was CPO monitors. CPO monitors can get pretty expensive, but in our case, our system was actually already looking into it. So when we got wind of it, we thought, maybe this will be something good for us. We deal with a very big geriatric population, so there's altered mental status, dementia. They just don't understand that they need to stay in bed. Some of them are very fast, so even if you have a bed alarm or chair alarm on them, they're not always going to stay put, and the nurses are not always going to be able to run to them. And the thing is we just don't have the staff availability during this time to have one-on-one sitters with everyone who needs a one-on-one sitter. So a CPO monitor is actually a video monitoring system. It is centrally watched at one of our larger hospitals, just like our telemetry monitors are centrally monitored. And what we do is we sign the patient up, we tell them exactly what we are looking for, whether it is getting out of the bed, maybe it's just pulling out IV lines. They're actually able to talk to the patient. So even if they have a little bit of dementia, hearing a voice will sometimes stop them in their tracks. These CPO monitors are able to talk to them and try to get them to stay put, but they are also able to very quickly call us on the floor to say, hey, you need to get in there. We've initiated that, and we're going to be keeping a log of every single patient we use it in, because even though we're doing several different initiatives right now, we want to be able to track the data a little bit. And so the CPO monitors, how many patients we use them on and for how long, will be some of the data that we can look at a little bit later. Dispersal of staff. So as the unit manager, one of the things that I noticed is that staff, obviously they do their med passes, they do their wound care, they're doing assessments, but they spend a large amount of time at the nurses station. Our nurses station is, because we're in an older hospital, not set up to where it has an actual visual down the hallway. So I feel as though what was happening is nurses were going to the nurses station to sit down and chart. Your call bells are going off all the time. So they're not really having that one-on-one observation that they could be having with the patients. A large part they're lollygagging, I mean, they're just trying to kind of take a break and visit with one another, but it's to the detriment of the patient. So what we did was we put workstations completely down the hallways. We allow a charge nurse and possibly a CNA to sit at the desk to answer calls. We're working on getting a unit secretary right now, but we've completely put staff down the hallways. They are on WOWs, which are workstations on wheels. We've put comfortable chairs down there for them, and it has been beautiful from what we've seen so far. They're always down the hall. The minute a call light goes off, I could be sitting at the nurse's station answering the call light. A nurse is already in that room. We've never had that before. So I believe that this is already showing that it's going to be a huge win for us. So obviously we are still early on in our fall initiative, but you want to study. This is the next part of the PDSA. With studying what you're doing, all of your interventions, the data that you're collecting right now, you have to do that with meetings. So anytime you're doing any type of root cause, you should really be having weekly meetings every 2 times a week if you need, but we've decided that weekly is good. In this weekly meeting, we have actually included a staff level nurse. So we pretty much decided we need a nurse champion, because managers are not always on the floor. They are in their office, doing other things. I can't always sit at the nurses station with them. So by having a nurse champion, not only are the peers going to look at that nurse champion as someone who is wanting to implement these things, it's going to help the nurses to not have pushback, because they see one of their peers being a cheerleader for it. Also in real time, they'll be able to do the auditing and things like that. Whereas, leaders are usually in their office or in meetings and things like that. So she'll be able to do all the auditing. So we have made a nurse champion who will help us to study the information, go through computer charting, look at fall risk scales and things like that. we're going to every week observe our audit tools. The audit tools that we have are obviously going to be how many patients are being put on the CPO monitors, how many people are actually complying with the no pass zone. That'll just be a visual down the hall that, maybe housekeeper was walking down the hallway and a bed alarm or a chair alarm or IV pump for that matter was going off, or a patient was yelling. Did they bypass that room, or did they go into the room and call for assistance? In these meetings where we are studying all of these things, we also need to determine if alterations to the plan is needed. This is great because we don't want anyone to think that, we set forth with this and this is what we're doing regardless of how anyone feels about it. One case in point that I didn't mention as one of the big initiatives where we felt that our rooms were a little bit cluttered, which could lead to falls. We had received new beds at the end of last year. They actually had bed poles on them for IV pumps, so we were able to pull all of our IV poles out. And we thought that was going to be great, declutter the room. Well, all of our feedback that came back from staff, the rehab department, everyone was, we want the IV poles back. By putting the poles on the beds, we're having to do extensions. Extensions for the IVs are even more of a trip hazard. A lot of these patients are SNF patients, rehab, so it's very time consuming for the therapist to have to take the pump off the bed, now put it on a rolling IV pole that we used to have in the rooms. So we got staff feedback and we decided that we're going to go ahead and, let them have the IV poles in the room. So we are able during the study phases to change things around. It doesn't have to be set in stone right then and there. You have to know what works and what doesn't and when it's time to change it. So the last part of the module is ACT. This is where we would determine if the initiative was a success or a failure. So obviously right here, we're still very new into this. It's been several weeks. We've rolled out quite a few things. Knock on wood, we have not had a fall yet. The patients are loving having the nursing staff down the hall. I feel like there's a lot of team engagement right now with the initiative. No, we have not had a fall, so technically we are meeting goal right now. We actually have until December 31st to not have a fall. And that actually goes back to the quality metrics that we have as a hospital. We just had a very large hospital merger, so our fiscal year used to be in October, from September the year before to October. We're changing our fiscal year to January, so they gave us a quality initiative from October to December to not have more than 3 falls. And unfortunately, by the time they rolled out those goals, the beginning of October, we did have 2 falls. So, we're on the cusp of, we really, really, really don't want to have another fall this year, but will these initiatives that we're putting in place help us for the following year as well? Because patient safety is obviously more important than meeting this quality goal. We don't want our patients to fall. It's not just about numbers. We don't want injuries. So this was my plan. So far it is working very well. You could see my QI proposal paper. I do have obviously a whole lot more information in there, but it's working out great. Doing the PDSA model really did help. Doing root cause analysis really did help. So thank you so much for listening. I hope it was good for you.